I have been asked to talk about chronic post-operative inflammation. So you do a wonderful uneventful cataract surgery. You have excellent early post-operative period. After 1 week, patient is unaided, 6, 6 and 6. You are very happy, and so is the patient happy and thankful to you. But then the problem starts after a few days, and patient comes back with variable inflammatory symptoms like congestion, watering. He complains of visual disturbances, and typically starts happening once you start tapering his steroids. So you hike the steroids up, and the patient becomes all right, but he comes back again once you start tapering the steroids again. So is this purely steroid, that the patient is having inflammation again because steroids are reduced? Is that the only reason? May not be. You have to look at other possibilities, and the most important possibility is chronic post-operative endophthalmitis. The other differential diagnosis like lens-induced uveitis or malpositioned IL causing iris chafing, or intraoperatively even IFIS can lead to this kind of picture, chronic inflammation. So the most important fact is chronic postoperative endophthalmitis. It's the inflammation of vitreous and anterior chamber, which is caused by infectious organisms 6 weeks after 6 weeks after surgery. Before that, it is called as acute, and if it happens very aggressively within the first 3 days, it is fulminant. So the chronic postoperative endophthalmitis is typically indolent, and it may persist for months together. It is often misdiagnosed as non-infectious recurrent iritis. Like TAS can be confused with the infectious severe acute infectious endophthalmitis. It can, this on the other side, this is an infectious condition which we can miss it as a iritis, recurrent iritis. So you keep the steroids keep going up and down, and the patient keeps coming back. Coming to microbiology, this is caused by indolent bacteria and fungi of low virulence. The bacteria is most commonly is Propionibacterium acnes, and while the fungus is Candida species are found to be most common. So this is the entire spectrum of various organisms that have been published as agents causing chronic endophthalmitis, and these are the fungal pathogens. It can be because of contaminated irrigating fluids, improper sterilization. So again and again, the importance of sterilization cannot be overemphasized. It has to be kept in mind. Another thing is sometimes if you keep the IOL before, it doesn't happen nowadays because we are mostly putting it on in our injectors before injecting in the eye directly. But with PMMA IOLs, that would have been the thing. You place it on the anterior surface of the eye, ocular surface. Risk factors are if there is a posterior capsular dehiscence, either intraoperatively or even after YAG capsulotomy. Diabetic patients, as Dr. Prasad has already said, these are the people who are prone to getting infections, and chronic endophthalmitis, they have a higher risk. So the patient comes with recurrent low-grade uveitis, which starts 2 to 3 months post-op and may persist for months together. The bacterial infections respond to steroids and again worsen on tapering, while the fungal ones, they may keep worsening after steroids are hiked. This usually pain and discomfort may or may not be present, but the patient definitely has visual symptoms. His vision is subnormal. He is not happy with his vision. While when you put the patient on slit lamp, you end up having seeing granulomatous uveitis. There are large keratic precipitates which are present over corneal endothelium and pigment dispersion over IOL surface. We can see the cells and flare in the anterior chamber. Typically, we see posterior capsular plaque, which is seen in this Propionibacterium infection. Vitritis may be mild. Only mild vitritis might be there, and that's what confuses you to think of it as iritis alone. The dense vitritis is seen if the infection is because staph epidermidis. So this is the typical capsular plaque as we can see in the blue arrow, and the granulomatous uveitis. In fungal infections, we end up seeing fluffy fungal balls as we can see in the left picture, and that in the vitreous you have string of pearl appearance. So the diagnosis is aqueous and vitreous tap, collecting the vitreous sample. You can do it if you are having a dry tap on trying to aspirate it with a needle alone. You can while doing vitrectomy, we can do it with a vitreous cutter, and it is necessary that to get a yield, we have to understand that these organisms are low virulent organisms, they are indolent organisms, so they take long, it's very difficult to get a culture positivity, as Dr. Seth has already said, that in only 25% of acute post-operative endophthalmitis you get culture positivity. It is even less in chronic. So if you see a plaque, it is necessary that the plaque is taken, the sample from plaque is taken. So you have to do gram stain and fungal and bacterial culture and look for antimicrobial sensitivity. We have to tell the microbiologists that you have to keep the samples. That typically within 48 to 72 hours they will discard, saying that there is no growth. We have to ask them to tell them that I'm suspecting a chronic infectious endophthalmitis, and keep the sample, keep the culture for longer time. You might grow something for a period of time. And in cases where you do not get culture positivity, this PCR, that is polymerase chain reaction, is very useful using universal bacterial primer. Treatment, the organisms are indolent in nature and they get sequestered in capsular bag, and when that happens, they are kind of protected from host immunological responses. So and they have variable virulence. So these tend to stick on for a long time in the eye. The organisms tend to stick on for the long time in the eye. So the treatments are the treatment strategies for bacterial infection is intraocular antibiotic injection, and typically vancomycin, which is a broad spectrum antibiotic, and P. acnes, which is found, it is seen in almost 48% of the patients of chronic endophthalmitis, responds very well to vancomycin. Only thing is that we have to make sure that it is not given along with the intravitreal injection. We have to go inside the capsular bag and inject the vancomycin injection, and repeated injections might be required. If you get a culture positivity and sensitivity to antibiotic, you may change the antibiotic depending on the second. The other is you can combine it with pars plana vitrectomy. But still, in these patients, we might have to go for along with pars plana vitrectomy if the infection keeps coming back, or if you are suspecting that there is a lot of sequestered material which is there in the capsular bag, then it is best to go out and go all out, all guns blazing, do vitrectomy, remove the IOL, do complete capsulectomy with depression, so that you are not leaving any capsular remnants, because if you leave behind capsular remnants in such cases, the infection is just going to keep coming back again and again. So we have to be if you think that it's a capsular bag is involved, best to remove it at the time of vitrectomy. The good thing is these people have better visual outcomes than the bacterial ones, at least, than acute postoperative endophthalmitis. Anatomical prognosis is also better. So as I said, if we are suspecting it is to reduce the recurrences, it is best to go ahead all guns blazing and remove the IOL. With fungal endophthalmitis, unfortunately, there is no protocol that can be that can be put. The treatment has to be very aggressive. We have to remove the IOL in these patients, and repeated intravitreal amphotericin or voriconazole injections might be necessary. Prolonged systemic antifungal therapy is also necessary in these patients, and they tend to have poorer prognosis with multiple recurrences. The other differentials may not be as sinister. It can be local cortical material